Thank you so much, guys, for contributing so far. Joe just shared a question, and I saw, Femi, that you have your hand up, so I'll address you in a second. Somebody asked, what are some of the specific health issues faced in the various sub-communities within the LGBTQ plus community? And that question is loaded because, like any community, in my opinion, there are tons of health issues. Specific to the LGBT community, maybe gender reassignment, you know, how you get addressed when you go to the doctor's office, how a nurse might approach you when they come into your room. How there are biases involved, which I'm going to talk about a little further in. But yes, this question is informed and educated, and I appreciate it. So I'll get into it a little more later, hopefully. Femi, you had your question. You had your hand up, I think.
Yeah, I did. Thank you. So, you know, it's funny when I think about the question, why does this matter? I think at first I'm a little, I guess, taken aback by the question, because fundamentally, you know, to me, I'm just like, well, why are we asking this question? Why does this matter? Because to me, it's just such a, you know, I hear that question and I think, well, why does it matter to take care of anyone, you know, regardless? But I don't know, I struggle with actually answering the question, why does this matter? Because I feel like it's something that should just be inherent and already ingrained into, you know, our psyche and how we move about the world. But I do think that it's important to have, you know, a discussion such as this one, because of some of the things that you just mentioned. You know, I used to work as an OR tech at Temple, and we were doing a lot of gender reaffirmation cases. And one thing that I noticed was that there was, you know, a certain amount of, I guess, emotional care and emotional labor and like emotional like strain that is required, that I think people don't necessarily recognize immediately or recognize the need or the necessity for it, compared to just, I guess, the general population of other patients. And it's incredibly important outside of the actual clinical care that's delivered, because that has such an impact on whether or not people will come back for care or seek care to begin with. And, you know, the lack of that, I think, creates a general mistrust of, you know, healthcare and healthcare institutions in a lot of marginalized communities. So, I mean, to answer that question, you know, it's important just so we can make sure that access to healthcare is there, and so that people feel like they can trust, you know, healthcare providers with their bodies, and also with, you know, their mind and emotions as well.
All right, thank you, Femi. I do appreciate your contribution. I did want to start with the broad questions just to bring people in, and I have no doubt that as healthcare workers, we all care about the patients that we take care of. But I also wanted to tailor it to a potential audience that may not be familiar with taking care of LGBTQ patients. So I wanted it to be broad. All right, so let me just briefly run through who I am, although Maureen did this already in the beginning. I'm a registered nurse at Temple Hospital. I'm currently enrolled in a doctoral program at Temple, the Doctor of Nursing Practice program. And I'm a former special education teacher of 7 years in the school district of Philadelphia, and a former television news reporter in Syracuse, New York, and Yonkers, New York. And I wrote and published 75 mostly gay poems and the COVID nurse experience in the last 2-3 years, both of those books. They're on Amazon if anybody's interested. So the question, what does it mean, LGBTQIA? And again, some people may be more familiar with this than others. So lesbian, gay, bisexual, transgender, queer, intersex, asexual, and other sexual and gender minorities. And as Femi mentioned and Maureen, the purpose is to provide the best quality healthcare for everyone. It's not just the people who might fit the mold of what we might consider normal. We have to open up our minds to other people, because everybody's out there, you know, and we have to be there for everyone. As we continue with the discussion, just remember that there are many terms out there and many definitions, and the definitions vary across communities, and patients may disagree with the definitions. Part of, on the bottom of my screen, you see there the website lgbtqiahealtheducation.org. I think it's a very good resource that if anybody's interested, they are very good at just breaking it down for everyone, so that if you, whatever background you're from, there's some good information out there for you. So this information here comes from nurse.org, and they give 10 tips on how to deal with LGBTQ patients. And one of them says, expand your knowledge of LGBTQ plus care. So you want to learn about sexual orientation, you want to learn about gender identity, and a lot of information is available from the National LGBT Health Center for Health Education, as I mentioned. And I just wanted to interject here, also based on some of the discussion so far, no one is an expert. I don't know if you guys agree with this, but none of us, no matter what our background is, in my opinion, is an expert about this. I kind of draw a comparison to racial disparities, health disparities. No one group of people, I think, are any more of an expert about a subject than others. Some of us might have more insight because of our personal experiences, but we don't have a monopoly on the information. Just because I identify as gay doesn't mean that I'm a know-it-all about how to deal with gay people or how to deal with other people of the LGBTQ community. So another tip that the nurse.org website has is to be aware of key LGBTQ definitions. Be aware of the definitions that are used when addressing the community. How to apply those terms in the clinical setting, and just be aware of gender identity terms like gender fluid or transgendered, because all of those things matter to people. Nurse.org also mentions that you should create a welcoming environment for your patients of all kinds, but when it comes to LGBTQ plus patients, you want to make sure that your non-discriminatory policies are visible. And to do that, sometimes you have to put up some pink triangles and rainbow flags just to make it obvious. And one thing that's very helpful for everyone is to have bathrooms that are available for everyone. And that when you put out pamphlets or ads about what's available at your health facility, make sure that it's all inclusive. Put all types of people out there. That never hurt any business, in my opinion. And healthcare is a business. It's not just taking care of sick people. It's about, you know, the sick people coming back to you for care, because as Femi mentioned, yeah, they'll be more likely to come back to you if they feel like you support their cause. So when creating a welcoming environment, I found a couple of examples of what that would look like. I know that Temple Hospital has gender neutral restrooms. And these are just examples of what those signs might look like to make people feel a certain way. And my question to you guys is, what impact might these signs have on people? If you come into a facility and you see these signs, positive or negative, it doesn't matter to me. What impact do you think a sign like this, or either one of those might have on people. You guys can either type your response or you can unmute yourself and just answer.
Well, Chad, I can, from my own personal experience, you know, I'm non-binary, so, you know, it makes me feel, you know, good when you know, when I'm in a facility and I see that, just because, you know, you mentioned the rainbow flags and, you know, that type of stuff. You know, a sign like this automatically lets me know that the facility is, you know, a more welcoming space. And, so you know, personally, you know, I really appreciate it.
Thank you, Joe. Anybody else wanted to chime in here?
I'm similar to what Joe's saying. When I see these signs, it's almost, it's relaxing in a way. I kind of, especially if I'm not familiar with like the business or like the space or wherever I'm in the building and I see a sign like that, it's kind of like, okay, I can like let out a sigh and understand that I know what kind of, I guess, thinking I'm dealing with. I mean, even though it doesn't say it all, but it's definitely relaxing and welcoming in a way.
So it adds to the comfort level. And just moving on, when you're working with an LGBT patient, you know, nurse.org also mentioned that we should just focus on the health issue at hand, to ask open-ended questions. Ask a question such as, is there anything else I should know that will help me provide better care for you? One thing I'm learning just as a nurse practitioner student is that if you leave the door open for people, a patient, that person is more likely to share information with you. And you want to know these things, either as a nurse practitioner, or any other interaction that you're having with a patient, because you want to be able to treat that patient for what might be causing a problem. And the last thing you want is for them to shut down on you and not tell you certain things. So just be aware of that. Jerry wrote on the chat, most restrooms in hospitals are non-gendered, single person rooms, default labeled men and women. Alternative is simply mark restroom without other designation. So Jerry, if you wanted to expound on that at all, do you find that to be a problem, Jerry, if you wanted to unmute your microphone?
I don't think it's a problem. I just think that it's, you know, it seems to me the simplest solution. Because when you're when you're in the hospital or a doctor's office and you ask where's the restroom, you're invariably pointed to a room which only accommodates one person. Right. So, you know, the question of it's labeled in a binary fashion, but if you simply put restroom on it, you solve the question. In my mind, you solve the question as well as getting more complex with it. It's just a thought.
No, thank you. I appreciate the thought, and I appreciate everyone who's contributing. And then another tip would be avoid questions that are meant to answer your own questions about transgender health. I think we all sort of fall into that category sometimes as healthcare workers, where you become curious, overly curious about a part of the person's story. And so you start to dig a little too much maybe, and it gets a little uncomfortable for the person. So, you know, be curious, I think, but, you know, don't be nosy. But again, no one's an expert, so everyone has to find their comfort level. So you guys have already been contributing to this topic, but I do have a couple of questions that I wanted to just give you time to maybe have a little more discussion on. What are your own ideas about making sure that the patients are comfortable? And how do you create a welcoming environment for your patients? And maybe what have you seen in your own workplace that would make everyone feel a little better about being there in that setting? If you'd like to text it, you can. If you'd like to unmute yourself and comment, you may, or we can move on. I'll move on for now, and feel free to jump in at any time if you'd like. All right, so the LGBTQIA Health Education website has a glossary of terms that I think is very helpful. It's for healthcare teams. And there are so many terms out there. And let me tell you, when you go to their website, you will see it. It's like a dictionary of its own. So yes, I think we all have to be familiar with it, not just, there's no one group I think that needs to be more familiar with it than others. And, you know, I'll share a story with you guys a little later about just that whole point of not considering yourself an expert. Because when you do, sometimes, you know, you get some egg in your face. But agender is one of them. A person who identifies as having no gender. An ally is a person who actively supports the rights of a marginalized community. An aromantic is a person who experiences little or no romantic attraction to others. And asexual is a person who experiences little or no sexual attraction to others. And then the terms go on and on, including bigender, who's a person who identifies as two genders. Biphobia is discrimination towards fear, marginalization, and hatred of bisexual people or those who are perceived as bisexual. The word bottom here is a slang term for genitals and buttocks, or it's used to refer to the receptive partner in anal sex. So, you know, I learned something new there. And cisgender is a person whose gender identity is consistent in a traditional sense with their sex assigned at birth. And just a couple more terms for you. Trans woman is a transgender person whose gender identity is girl, woman, female, and that term may be used to describe that person. Or transmasculine is a person who was assigned female sex at birth and identifies with masculinity to a greater extent than with femininity. And a couple more. Tucking is the process of hiding one's penis and testes with tape, tight shorts, or special undergarments. And two-spirit is a person who embodies both a masculine and a feminine spirit. Culture, specific terms used among Native Americans and First Nations peoples. So it varies, and I think it's quite interesting to just see the different terms that are out there. Have you guys heard any other terms that you might want to add to that? Or how comfortable might you be with these terms? What do you do when you mess up a term?
So can I have you go back one slide?
Sure. Let me go back.
Uh,
This one?
yeah, so the two-spirit. So a person who embodies both a masculine and a feminine spirit. Culture-specific term among Native Americans. So would that be what their understanding of it was?
You're saying with the Native American people?
Mm-hmm.
Well, I don't know. I found that term on the healtheducation.org website.
Mm-hmm.
It was interesting to me because I've never heard of it before either. Now, it would be interesting to hear, you know, if a Native American would chime in about that, because I don't know if they grow up with that term, if this is something that they just sort of live with as part of their culture. But again, I think the bigger picture is to be aware that there are these definitions out there that we don't know everything, you know.
Right.
Joe, you want
Joe
to?
has his hand up, yeah.
So I am not Native American myself, but my cousins are Ottawa. And so I actually asked them about this because I wasn't familiar with it myself. And a lot of different Native American communities historically have recognized more than two genders. And that is where you get into the two-spirit. It was a sort of it's a Native American cultural term for, you know, the gender fluidity. And so and I was actually going to type in a question that kind of goes to this. And I think the distinction between sex and gender is very important. And those often get mixed up. But yeah, that's essentially, it is in a lot of Native American communities, it's a way to express gender fluidity or non-binary.
Thank you so much, guys. Maureen, did you want to add anything else to what was already said? I think I kind of jumped to Joe before.
Right, that's good. That's helpful. Thank you. I was just curious. I've never heard of it before either.
Yeah, and again, I'm only scratching the surface, even based on the terms that they have on the LGBT Education Center website. So that's why I think I keep saying that nobody's an expert. You know, we'd like to think of ourselves as experts, but I think we have to just keep our minds open to what's out there. So,
hello?
Yes, go ahead.
Okay, I just want you to know that I think this is incredible, this presentation so far.
Thank you.
And just the very words sex and gender, that those were learning experiences for me. And simple thing like that, right? And
Right.
I screwed it up, right? So
and we all do, and I learn every day whenever I have an interaction with any type of patient.
yeah, so it's great to know these things. Yes, thank you.
Yeah,
that's all.
We fall on our faces all the time, but we have to stand up. Go ahead, Maureen.
So just so you know, there's a lot of terms because I've looked them up. Only because when I renewed my licensure this year for Pennsylvania, I have New Jersey and Pennsylvania. New Jersey didn't have anything about gender, but Pennsylvania did, and it had. And you have to understand, I've been a nurse for 37 years. So this is the first time in 37 years that I was asked to identify my gender. And then it had a lot of, did you renew yours too? And I went into work saying, hey guys, even though Joe and Alex had given us this, had talked to us at the executive board, I was not familiar with it. And when I brought it to work and I said, has anybody renewed their licensure? Because there's a lot of questions on there. I said, it used to be one or the other, okay, for 37 years for me. I should say 36, it's 37. So I come into this and I'm looking at, I said, there's a bunch of answers here. So for me, it was always one or the other for 36 years. I come into this to do my licensure and there's all these choices. So I have to go and research those choices because I had no idea. First of all, I didn't, it was always one or the other. So just so you know, Mayette, it's new to you, it's new to me, and Joe and Alex came to talk to us at the board meeting. It's very new and it is confusing. When I went to work, we went way into it. And I want to tell you, 90% of the nurses that I work with that day, and they're not my age, there's young nurses, they did not know. So this is all new to older nurses, maybe younger nurses, it's not. And one of the nurses I work with said, oh yeah, my daughter is becoming a nurse practitioner and that's what she's learning. So that's really where we don't understand some of these. And that's why I had asked you about that. And I still have a lot of questions. But anyway, so thank you. I just wanted to share that, Mayette. That is, it's just not you.
It's all of us. All right, let's just move on a little bit here. So this is another uncomfortable territory for some potentially. The question on the screen here is what comes to mind when you hear the word bias? And, just a quick answer would be fine if anybody wants to chime in here who hasn't had a chance to talk. And while you think about whether you want to chime in, I just want to say as a former teacher, I'm approaching this as a former teacher. I don't like to lecture for minutes and minutes at a time without having some kind of interaction with the people that I'm talking to, because inevitably the students would start finding things to distract themselves with, such as their cell phones or yeah, maybe another student next to them. So anybody, just tell me what you think of the word bias in your opinion. Go ahead, Jerry.
So I'm a little bit of background. I am worked for PASNEP since day one, and involved in negotiating several contracts at Temple. Chad, and you sort of got there after I left. I'm also a gay man who has been out for close to 50 years, and you know, the changing landscape of the perception of these issues, you know, is pretty astonishing over that whole time. And I just want to chime in with the notion that, to me, bias is only present when there is an explicit antipathy. In other words, ignorance is not bias. Lack of familiarity is not bias. And, you know, in this context, as in many contexts, you know, it's a challenge to us to listen and be open to everybody that we meet, and their differences on numerous dimensions. Because I remember when the huge fear was that as a gay person, one's partner would not be allowed to visit you in the hospital because they weren't related, quote unquote. You know, and the innumerable times that people asked me, you know, if I was married, or assumed that my partner was a woman. You know, I have always gently corrected them and not assumed bias. And I think that it's important just to have a clear understanding of what bias really means. Now, you know, I have come across people in my work life and in the union who were biased. They're certainly out there, and I think that you know, we just need to be aware of what it really means.
Yeah, it's there, and you know, I don't think anyone is exceptional when it comes to bias. So what I have from my research with the LGBTQ Health Education Center is that internal bias affects the way we talk to or behave with a patient, or you can apply it to, you know, each other, everyone. And that biases in healthcare can lead to inequitable care. And you end up with biased clinical decisions. And we communicate through body language, of course, and with words, but I think I read somewhere that most of our communication is through body language. And this can be called microaggressions. So an example might be, you know, you walk into a patient's room and you don't like their hair, or you don't like their smell, or you don't like the way the room is messed up because it doesn't quite fit with the way you have your house. And so, you know, you might make a face that you're not even aware of. And so the patient reads that before you even say hello. And so we have to be aware of that being a possibility. And we all carry that with us. So I always ask myself, you know, am I guilty of bias? And it's not every time that I try to rectify that, honestly, because it does take some work, and not everybody likes to do the work that's involved. We all have the biases. It's based on cultural stereotypes that are embedded in our belief system from childhood, and it's kind of wired into us. It's a social thing. And then there was a study done by Harvard. It's called the sexually implicit assessment test. This was in 2015, and it found that heterosexual physicians and nurses implicitly favored heterosexual people over gay and lesbian people. And this is the website there. I think I should be able to copy it and paste it for you. But if not, I did share my PowerPoint in my session, so you'll be able to access it. Another study found that 38% of lesbian and gay men showed implicit preferences for straight people. So the point there is that even members of the LGBTQ community have their own biases that are quote unquote pro-heterosexual. So it just shows you the power of your upbringing, the power of what you're taught from day one as a child. So,
Excuse me.
yes, go ahead, please, Maya.
Yeah, what's that mean? Go back to the former slide.
Okay.
Yeah, what's this mean? 38% of lesbian and gay men showed implicit preferences for straight people as healthcare professionals or just as people?
I would have to dig a little more into the study itself, but my understanding is that, okay, let me just put it this way. I'm a gay man, I'm a gay nurse. But if I was part of that 38% of the people who were studied, that I would show more of a preference for a heterosexual patient as opposed to a LGBTQIA patient.
Oh, I see what you're saying.
Yeah, that maybe I'd be more comfortable working with a straight patient as opposed to someone who's not straight. And, you know, it's incredible that, I mean, well, not incredible, but it's interesting that close to 50% of those surveyed do have that preference. And it works in other situations too, I think, when it comes to other minority groups. You know, so again, it's just to raise awareness about it.
Mm-hmm.
Jerry, did you raise your hand again?
Me?
Jerry?
Oh,
No.
Jerry.
Okay, okay.
You have to close it off after, when you answer my question, you have to turn it off as the host.
All right, I'll figure that out probably by next year. Maureen, unmute yourself. We can't hear you, Maureen.
Joe, can you do it? I don't know how to do it. It doesn't matter.
I'm
That's
not set up as the host.
Oh, I am. All right.
I can click on Jerry and
It doesn't matter. Oh,
It's
It's,
okay.
yeah, it's not gonna.
it's not the end of the world.
No, I think
All right.
I
So again, more questions for you is, you know, what are some of your ideas about bias and what general practices might we be able to use to overcome those biases? And your favorite question, Femi, is why does this matter? Why does it matter for all of us to be aware of these biases? Anyone can chime in if you'd like.
Well, I was gonna say, how do we overcome bias? I think education is key. You know, things like what we're doing right now are very important. And, you know, and to the why does this matter? Hopefully one day it won't. You know, it would be great to not, you know, have to constantly educating. I know, Chad, I can't speak for you, but I know it does get tiring, like the constant education, and it's I can only imagine. But yeah, I think education is a big key.
Okay, very, very good. Thank you.
Chad, I think something, I think.
That Paige.
Yeah.
Hi, Paige.
Hi, Chad. I think we do need a lot of education. I know PM&R had one in service maybe earlier last year. And, you know, it covered some of this, but it also just, you know, to your point, it shows how much we don't know. Something that I try to do with all my patients is ask, what would you like me to call you? So I don't walk into a room and assume that it's Mr. So-and-so. I ask them, what do you want me to call you? And that creates that rapport, but it also, you know, if you are working with somebody who is in the LGBTQ+ community, it gives them the opportunity to say how they want to be addressed, and then you can try to prevent those instances where maybe the wrong pronoun is used, because that can be very emotionally damaging to somebody. And like I was saying earlier, I had that patient who I saw as an outpatient, and part of the reason she was coming to me was because she felt like a guinea pig at the one place she had been. And then at another place, the therapist had mistakenly used the wrong pronoun. And that was enough for her to feel unwelcomed there. And so, you know, having that awareness of asking that simple question, how would you like to be addressed? What can I, you know, what name should I use with you? Or what pronoun or whatever, can open the door to trust, open the door to letting you know how to interact with the person and create that rapport and trust and respect. And that's what's obviously needed to be able to provide the best care to somebody, is that they trust you.
Thank you, Paige. Appreciate it. Alex, you raised your hand.
Yes, hi.
I figured out how to lower the hand too, by the way. There's a button that says lower hand. So I got this. Go ahead, Alex.
I'm really enjoying this presentation. One point I'd like to make is the hospital is one of many places that an LGBTQ person will find themselves in the course of their care or their lives. And there are so many other places where our society falls short in offering services. In Pittsburgh, when I lived there about 10 years ago, 2 trans youth that I mentored and befriended had come to Pittsburgh for the unique services provided by a gender reassignment nonprofit called PERSAD, and they do both mental health and you know, guiding them through the process of transition. And they could not find housing. And they also, the way that in transition, they had trouble keeping a job. And if you think about places where an entry-level person might seek a job, it's very forward-facing as far as service industry, like a restaurant or something like that. There just weren't, they also didn't feel comfortable, they didn't feel comfortable in their bodies enough to like really be in an employment setting. So they had low income. And by the time that, and there's also the factor of dysmorphia of either eating disorder or other things that come with that. So in the care of an acute care setting in a hospital, the path that led them there, whether it's you know, if it's related to their identity, the bedside person is a very important ally. It can be a very important ally in asking the right questions about their needs and addressing them the right way and making them feel comfortable after a lot of the things that they can go through and face in our world. So I think that it's great that the caregivers are at least acknowledging the issues here.
All right. Thank you so much, Alex, for that perspective. Yes, Maureen?
I just want to say, yes, it is education because, again, I had to educate myself when I renewed my licensure this year for Pennsylvania. But also, I have to say, I'm an old nurse. I've been around for a long time. In 1975.
You don't look like an old nurse.
I am. In 1975, in high school, my best friend, one of my closest friends, was gay. And he didn't hide it. And again, I didn't think anything of it. So, and I also was brought up in a very religious, strict background. So it didn't matter. It was part of our youth groups and we just embraced them. And so, but at that time, that wasn't to be embraced in the 70s. I mean, I can't speak for that, but I mean, as a high school, in high school, you know, people would say, why are you friends with him or whatever. But then we, I have to say that this is a paradigm shift. It's not something that is easy. For me, I think it's easy. I don't know for other people. And we all have bias to some degree. So the key here is, it is education and an understanding. to what we need to do for care. For me, it never mattered who you were, what you did. And my first reassignment surgery patient was a patient at a Catholic hospital that I worked at that was in an ICU that was septic. So I didn't think anything of that either because of my upbringing. So it's really our upbringing. It's also generational, and it's a paradigm shift that requires a better understanding and also education. So I think that's really the direction that has to happen. So that's just my thoughts.
Thanks, Maureen. Yeah, it takes work. It absolutely takes work, and it doesn't just
Time. It's going to take time, I think, Chad, because until the AIDS, if anybody was around in the 80s when AIDS came up, and I just finished reading the book and the band played on, you know, it's a big shift. And so, and I read that book back in the 80s. I was around when the, you know, full-blown AIDS and you didn't want to take care of the patient, et cetera. And I'll never forget my first patient that had what they called full-blown AIDS in 1984. And nobody wanted to take care of that patient because they didn't want to get AIDS. And there was it took a lot of years and fighting and politics. It really took a long time before people began to understand and lose that bias that we're talking about. For me, I have to say, maybe I had some, but not that much just because of my upbringing. But even in the workplace, you know, when I would take care of a patient, I would think that's somebody's child. I had just had a baby when I became a nurse. I'm thinking, oh my gosh. And that's the way I looked at care. So, but that's not the way that everybody looks at care. And so I'm going to say that this is great that we're doing this. And this is going to be a shift over time. It's not going to happen right away. I do think that the education is important, and time and politics.
Yeah, I agree with you, Maureen. It definitely takes time, work, and willingness to be educated. Because if you're not willing to be educated, you're stuck where you are.
Yes.
That's the way I see it.
In education, there was something we learned about a child's willingness to learn, or a child's readiness to learn. If the child is not ready or willing to learn, then you can teach them whatever you want to teach, but they're not going to learn it because they're not there. And I think it's the same thing for adult learners. We only have about 5 more minutes, I think, so let me move on. I have a section about pronouns, which we've sort of talked about already, but that's one of the big things with the population that we're talking about is the different pronouns: she, her, hers, he, him, his. And it sort of sometimes falls into the category of female and feminine as opposed to male and masculine. But I put a question mark next to that because the source of this information was from the University of Wisconsin at Milwaukee. And they mentioned that, you know, not everyone falls into that category, or not everyone identifies as male, female, or, you know, goes with the feminine, female thing and the male masculine designation. Some people prefer to just be called by their name. So right here is just a couple of other aspects of the pronoun part. And I thought I was looking at something in a foreign language for some of it. If you look, I circled the part that makes sense to most of us: he, she, they, him, her, them, his, her, their, his, hers, theirs, himself, herself. But if you look down near the bottom, you see these other ones like Z and here and here's and here self. This is not a foreign language. This is something that people are using now to identify themselves in English. Am I familiar with it? No. I'm familiar with some of it. But again, it just reminds me that we're constantly having to educate ourselves, because what was normal, say 5-10 years ago, isn't necessarily what's normal now. I started going out to the gay clubs, you know, when I was, well, let's just go with the year. But like in 1998, 99 is when I started hitting the clubs. And, you know, back then I was, you know, young. I was like the hip crowd. And, you know, now later on in life, I run into people who are in their 20s now, and the language that they speak is completely different than the language that I speak. So if you mess up, what do? You say, sorry, I meant to say, him or her. Quick story for you. There's a coffee shop that I go to where one of the workers, on that person's name tag, it says they pronouns, but the person to me looks like a male. So, I go there almost every day, and once or twice I've said, hey, sir, how are you? And it's right after you say it that you realize, oh my God, I just really messed up here. And I'm a member of the LGBT community. So what I do is I just say, I'm sorry. I mess up too. And then the person says, it's okay, no problem. So the University of Wisconsin wants us to not dwell on the subject, have a quick conversation about it, and move on. Because again, we're not all experts. And real quick, I'll tell you that Temple University itself has an LGBTQ task force, which I'm a part of. We have periodic meetings and community events, and it's wonderful for all of us to get together and just talk about the different issues in our community. We help provide education for staff. We have conversations about employee benefits related to LGBTQ life. And yes, we have the gender neutral bathroom signs at Temple. Does anybody else have a contribution in terms of what their workplace might have that makes people feel comfortable? All right, I'll move on. So Temple in 2018 got a designation from the Healthcare Equality Index, known as a leadership position from the Healthcare Equality Index, which was a big deal for Temple. And right here you see Temple on its website, just sort of touting the fact that it got that designation. Even during COVID, the healthcare task force, the LGBTQ task force, has been trying to have events in the community. This picture was from a prior community event. I think it was Outfest, when we could, we didn't have COVID at the time, so all of us were able to go and just do community outreach and be part of that. And that's me in the middle. And right there is another event that I had participated in called the Pride Run. And the point of this is that, if you show yourself as part of the healthcare organization in the community, then the community is more likely to come to you for healthcare reasons. And these are my references here, which I've already mentioned throughout the presentation. And one last plug for my books. There are 75 mostly gay poems and the COVID nurse experience, which both of these are on Amazon if you have any interest. Okay.
Thank you, Chad.
Thank you.
Oh, you're welcome.
Great.
If you guys have any questions or you have anything you'd like to add, please feel free to do so. I don't know if we have any more time, but by all means, share what you need to share. And I see someone wrote, Joe, thank you.
Thank you.
Thank you.
So what happens next, guys?
Sangria. No. No, wait. I have the schedule here from 3 to 6. I don't know if you signed up, chat, but there's casino games. Or 3 to 7, there's the socialization breakout room, which is virtual happy hour, and it says Solidarity Sangria. That's where I got the sangria from. At 3:30.